Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. This is a platform where research meets understanding. I'm so happy today to bring on board a female guest researcher who will be discussing on maternal mortality, the services women in Kaduna have access to. Women in Kaduna have access to, and basically we'll be looking at the length and breadth of maternal mortality, right from all perinatal services available to women in Kaduna State. So it's right I bring in a learned scholar who has first-hand experience and impact in this area. Please join me to welcome Mrs. Aimee Osamudiamen Chris. How are you doing, ma?
I'm doing very fine, ma. And you?
I'm so good. Thank you so much for honoring my invite. You have a beautiful smile.
Thank you very much. I'm grateful, ma.
Okay. Basically, before we go start discussing, let's give our viewers, our audience, an overview of Mrs. Aimee Osamudiamen. She is a Nigerian scholar, researcher, and mental health expert whose academic and professional engagements focus on sociology, public health, and sustainable development. She's affiliated with Ahmadu Bello University, Zaria, Kaduna State University, and the Nigerian Institute of Leather and Science Technology, NILES, Zaria, where she contributes to teaching, curriculum development, and mentorship of students in areas such as contemporary social problems, national ethics, and values. Her research addresses pressing social and health issues with particular emphasis on maternal health care services, patterns of access, attitude, and utilization of health services and facilities by women of childbearing age, and the systematic challenges that hinder access and quality in Nigeria's health sector. In addition to maternal and reproductive health, her work also interrogates the intersection of wellness, illness, and social protection, alongside broader concerns of governance, accountability, and institutional reform. As a mental health expert, she integrates academic scholarship with advocacy, designing interventions and awareness initiatives that promote mental health wellness, reduce stigma, and enhance community access to psychological support. By combining rigorous sociological research with practical approaches to health services utilization and mental health care, Mrs. Aimee Osamudiamen Chris contributes to advancing knowledge, policy, and practice in ways that foster equity, social protection, and sustainable development in Nigeria. Basically, before we go into discussion, normally what I do as a preamble, I look at tweets. What are Nigerians saying? What are people around the globe saying about the topic of discussion? We're looking at maternal health today, so let's look at what people are talking about. The first tweet is from Niger Pulse, where FCT Minister Wiki takes bold step for Nigerian mothers, free mother baby kits, and clean energy solutions. Show true leadership in healthcare sovereignty. They're talking about Wiki contribution. I guess this is a recent tweet, like 1 hour ago. His contribution to maternal health, I guess in Abuja, where he leads. The second tweet is from AN Afghanistan. Many provinces in Afghanistan lack functioning maternity wards. Health workers report medicine shortages, staff overwork, and deaths. The ban on midwifery schools is cutting off a critical pipeline for new care providers. The last tweet is from UNFPA Tanzania, where they're talking about reducing maternal mortality in Tanzania, evidence, innovation, and partnership pathways. Maternal health is more than a health priority. It is a cornerstone of human capital development and a reflection of our collective commitment to protecting the rights and dignity of women and girls. One thing with maternal mortality, it's a generalized issue. It's not only in Kaduna or in Nigeria. It's everywhere, and women will keep giving birth. So, Miss Aimee, Miss Osamudiamen, I like to call people by the traditional names. So, Miss Chris, anyone I'm comfortable with calling you. Thank you so much once again for honoring the invite. Basically, we're looking at maternal health today. So, what is maternal health, ma?
Okay, when we see that women are just unique in their own ways, and when we see the uniqueness of women, we see that maternal health is very paramount in our society. So when we're talking about maternal health, we said maternal health is that the health of a woman before, after, and during pregnancy. So we say that this health of a woman, it covers all aspects of a woman, because the woman's well-being is the priority, is her priority, and it's also the priority of the nation. So we see that especially 42 hours after birth, we see that this the health of a woman is very paramount. She don't just give birth and you just feel, oh, it's okay, she's giving birth. So we see that it's both a preventive and also a curative service. We see that these healthcare services have to do with antenatal, it has to do with delivery services, it also has to do with postnatal services, it has to do with the basic obstetric care that she needs after being given birth, or any other service that is going to do what save her from dying. Because you see that women are in their uniqueness, just as I said, their well-being is the priority of the nation, and then we need to see that good health is the basic for every woman. So we do not live in a society whereby we say, okay, she's just a woman, she should take care of herself. We see that good health is a necessity. So that's why we are always conscious about maternal health.
Thank you so much, Ma. The annual from the paper I quote, annual maternal deaths varies between geopolitical zones in Nigeria, with 165 in southwest, 286 in southeast, 1,025 in northwest, compared to 1,549 in northeast. What contributes to regional differences in statistics? Because they are all different, and it's as if they are not, it's the same states, but different, the same place, but different areas. What contributes to difference in statistics regionally?
That's a very beautiful one. We see that one of the regional differences or variation in these statistics is the uniqueness of every area. For example, I will give it a divide so we can understand why these differences exist. When we are coming from the north, we see that in the northwest and the northeast, we have higher variation as compared to the northwest and the south and the eastern regions. Reasons being that in the north, we have one basic issue, which is the educational factor. When we come to the north, we see that education is poor. A female is given out in marriage very early, so she's not even having the opportunity to go to school. We also see that this lower educational factor now affects them economically, because if you are not able to go to school and apply the needed knowledge you need in the society, you discover that poverty is your name. So therefore, you can't even have access to money. Most women are not working; they are just full housewives. They don't have any income, they don't have any say. Then we now come to the cultural values again that the society upheld to in the north. Because in the north, a woman doesn't have a right to her health. It is a man who decides. That is the spouse must decide, okay, this is when to go to the hospital. Must need to permit you to go to the hospital. If not, you're not going to go. And even when he gives you permission to go to the hospital, he must provide for you. So even if he says, okay, go to the hospital, and then he doesn't provide for you, it's as good as you not going. So we see that these differences, this variation is in comparison to the women in the South. You see, most women in the South are educated. Most women in the South, they have their own income earning. Even if a woman doesn't go to school, she's working or she's doing something basically that gives her a little earnings. And so once she can earn something for herself, if she feels discomfort during pregnancy, she can easily go to the hospital. Some women in the north, they can't even step out of the house without their male counterparts or the eldest woman in the house going out with her to the hospital, or basically giving her an informed consent to go to the clinic. So these are some of the factors. Then when we come to the northeast now, where we also see this variation, we see that because of the displacement for people, security issues, we see issues of infrastructural problems. You may not even see the presence of a healthcare facility, because this work was done amongst primary health for primary health centers. We see that some of all these communities don't even have primary health centers. Where you even see some, they are dilapidated or not even health workers, because all the health workers have jacked back to other better regions. So nobody is there or available to attend to you when you come there. And then we also see the use of the traditional birth attendants as also a factor, because we see that most in our northern region, they believe in using the lesser or the cheaper labor instead of you to go to the hospital when you are having any health challenge. You just have an elderly woman that is okay, she practices nursing, not that you know anything about her, so they just go to meet her. Then we also have the geographical and transportation issues, distance to health facility, then in terms of transportation, no good road, bad roads, access. So that's why we see that access is basically a factor. And so when we see that all these factors, you see that they are basically contributing factors to why we have the higher maternal mortality in this region as compared to the southern region. They also have health financing and also the aspect of giving donors coming into facilitating, financing the health factors. We see that in the south, we have more NGOs who want to stay in the south, help women who are having issues than coming to the north because of the volatile region, or if they just say, it's not a region, or we don't want to come here, or we are scared, the security is not, we are not safe here, we are not good to go. So all these factors in their own dynamics, they contribute to the high maternal mortality we experience in the northwest and in the northeast in comparison to the south.
Thank you so much, Ma, for that explanation, for giving the elaborate explanation. Actually, I'm sure everyone who listens to this or is watching this, they have an overview of why there is different statistics regionally, and it's actually beyond what I anticipated it to be. Thank you so much. That's why we are bringing people like you on board to explain. Dr. Chris, in Kaduna State, the maternal mortality ratio is 1,025 per 100,000, and only 35.5% delivery were taken by health professionals from the paper. Who are the people delivering the rest? Are they ghost workers? Who are delivering the remaining women?
Yes, like I said, we see that this study actually is engaged. It's a community service. It's a community study. It was a cross-sectional study. So when we engaged the community, what we discovered was that even women that go for antenatal, that's they go to attend antenatal in the former hospital, when it's time for delivery, they prefer to use a traditional birth attendant, or basically home delivery, or basically some unskilled, we have the is it the quacks or what do you call them? They are unskilled workers, but they will tell you, so amount of delivery. I've delivered this person, I'm the one that took this childbirth. And then we see that basically those are the group of people that take deliveries. Despite the fact that we have the trained traditional birth attendants, they are not so much even utilized, because one of the basic reasons you see women, just like I said, the financing. So they don't now want to go to the hospital to have their normal deliveries, because they feel the hospital will charge them to give them, the hospital will charge them money for delivery, the hospital will tell them to bring hospital items, but these women at home, they just take their delivery free of charge for them. Highest, they just tell them to give them a token, and then they don't look at the health implications, or when they have bleeding, or if they come to some complications, how these women will handle them, because they have zero referrals, most of them. They even don't have that experience. I was conversing with one, and then if you see some of the way they induce these women to give birth, you just be like, wow, can you imagine? So, but the women don't, all they know is that they have the cheaper means of getting what they want. And then some, incidentally, labor could just come up when they are home, and then automatically they don't have a choice than to give birth by themselves. So these are the rest, or the category of the rest people that we see, that the TBAs the unskilled health attendants, the ones that claim to have or some faith-based. We also have this faith-based clinic, or maybe you see them using both the Christians and both the Muslims, just the faith-based. So
Yeah.
those are the rest that take these deliveries.
Okay, thank you so much, Ma, for that. And one thing is, giving birth is a natural process. So, for most people, the fact that it's a natural process, everyone thinks they can deliver someone. Actually, I'm not the one delivering someone. It's you are just guiding, and the baby comes out on its own. But one thing is, you have the knowledge, the skills, the expertise to effectively guide a mother to deliver, to effectively take care of the mother after she delivers, to effectively know when to refer a mother if there are complications. So these are things that separate trained health workers and untrained birth attendants. So thank you so much, Ma, for that. I would like to know basically you talked about sterilization frequently in the paper, and sterilization can mean different things. Are you sterilizing an instrument? Sterilization can come as a way of preventing fertilization, reproductive health, like someone not being able to give birth. So, in context of this paper, what are you trying to say in regards to sterilization?
Yes, in the context of this paper, we spoke about sterilization from the context of infection. That's, that once a woman contacts infection at the point of delivery, all these factors are factors that can actually lead to maternal mortality, because we see that some of the health facilities, they don't even have autoclaving machines. They don't even have the meaningful process, or engage in the meaningful process of sterilizing their equipment that they use for delivery and all those their delivery packs. You even see as little as hand gloves. Some facilities don't have hand gloves. So when we talk about sterilization, we're talking about protecting our basic equipment that will not even lead to a woman contacting infection. Because you see that once a woman contacts any infection, it affects her. And once these infections, they are not treated timely, we see that all these factors, they are factors that contribute to maternal mortality.
Thank you so much, Ma, for that. I believe anyone who is listening or watching this, they get the context in which we are trying to explain to, like you and your team are trying to explain sterilization. Also from the paper, I quote, utilization of certain health services, especially modern delivery, is low. We're talking about people having access to health services in Kaduna State. What health services are available to residents?
Okay, well, in our PhCs that the study was actually conducted, we see that basically in the PhCs we have antenatal services. And we know that, just like we know that the use of antenatal is for a woman, is for preventive care. So throughout your pregnancy, you're supposed to attend the antenatal services, which is a modern service. So you know what is the fate of your child, how's the childbearing, everything about the child. Then we also have the postnatal service. We also have the family planning service, because you see, family planning is actually very effective for you to know how to space your child, for you to know the most appropriate, or you choose, because you have the right to choose the appropriate planning system you want to use, both for you and your spouse, to enable you to be healthy, and then to enable you to also bring children to the society that you can take care of. So we see that these services, amongst health education, they are all services, immunization, so they are all services that are provided in the primary health center. These are the services that are mostly utilized in these health centers. Just that some of them give delivery, while some don't give delivery services. Then when we talk about those that are not utilized, basically we see that the cesarean sections and then the blood transfusions, they really don't give those services at primary health center levels.
Thank you so much for enlisting the other health services that are available to women residents in Kaduna State. And I believe those who don't know the services available will be able to access the services, especially in primary health centers in the state. what are hypertensive disorders in pregnancy? I know many people are thinking hypertension only. Some people have this notion hypertension only is for men, hypertension is for women. When you are pregnant, it's only pregnancy, nothing happens to you, you don't get diabetes, you don't have issues. But they know that even pregnancy increases your susceptibility to some of these conditions. So what are the hypertensive disorders that are present in pregnancy?
Okay, some of the hypertensive disorders that are pregnant and that are effective in pregnancy, just like we have the gestational hypertension, that is pregnancy-induced hypertension, which occurs basically from 20 weeks during pregnancy. We also have eclampsia. We have eclampsia. We also have the chronic hypertension. That is those people that already have hypertension before taking in. So we see that all this hypertension, they need to be, you need to diagnose the woman early enough so that you could know the preventive measures on how she can cope during pregnancy, after pregnancy, to enable her to be healthy and her child to be healthy.
Thank you so much, Ma, for that. Actually, what people don't know is why one of the reasons you should check your health indices regularly, such as your blood pressure, is to be able to monitor it, to be able to take care of or gauge it, so that if at all you want to get pregnant, you get pregnant. There is a follow-up on the drugs you can take to be able to gauge your blood pressure in pregnancy, so it doesn't affect you or your child negatively. There are people who don't attend antenatal services. When you attend antenatal service, that's where they check your pulse, your blood pressure. They don't check it, they don't know it. You don't know you have high blood pressure. You go into eclampsia. Anything can happen to you. You have it can affect any of the organs in your body. It can damage your kidney, can lead to stroke, can damage your brain. So these are things I feel not just women but also the men around us should know. For a woman, when she gets pregnant, are you checking your blood pressure? What is your blood pressure? A woman told you she went for antenatal today. You shouldn't ask her, what did they share for you? Did they give you coke? Did they give you donuts? No, those are not the questions you should ask. Ask her what they checked your urine, what did they say about it? When they checked your blood pressure, what did they say about it? When they check your pulse, what did they say about it? Those are things you ask. Those are things you ask. You don't ask how many women were there? Was there a queue? Did you sleep? Was it? No, those are not the questions you ask. You ask about the things you went for antenatal for, and this is how you help. When a woman knows you care about it, she will also monitor it. But when it's only her, especially for pregnant women, some women even have amnesia during pregnancy. Those are the things, conditions they have. She forgets, you understand? So not just women, but people around women who are pregnant should also help monitor these indices for women. So thank you, Ma, for elaborating on that.
Thank you.
From the paper, despite the fact that operating hours and other public health facilities schedules remain limited to access and use, especially at the PHCs level, as most of the LGA facilities do not open on weekends and run only on shifts. I'm just knowing of this, that they don't open on weekends, which is unfortunate, that they work shifts based. What factors affect access and use of primary health centers in Kaduna State?
Okay, just like the paper highlighted, we see that one basic thing we see in the health sector, we're supposed to have 24 hours, that's round the clock shift. But we see that it is absent in some of the centers, where you see that some centers they just run only one single shift. And we see anything that has to do with health, a woman's health. Childbirth is not something you pre-plan. It can occur at any time, in the middle of the night, in the whatever time. And so therefore, one of the hindrances in access, it means that you can come to the facility, nobody there. And then we have shortage in manpower too, because we see that most health facilities, they lack adequately trained personnel. And even when we have the trained personnel, they are short in numbers. Then we also see another factor has to even do with the referral, because some complications or major complications cannot be handled at the PHC levels. They have to be referred to secondary or tertiary institution. Now, when the secondary or tertiary institution, there are no proper referral channels, we see that all these factors contribute to utilization and access. Then we also see that when the staffs, maybe they give this nonchalant attitude to women. You've heard about women who come to the center and complain that, oh, the staffs were shouting at us, why are you coming now? Do you need to wait until the baby's head is almost out before you come to the health facility? So we see that all these are even most factors that hamper delivery, because when a woman will tell you, okay, the first time I went there, they were just shouting on me, I came late and this and that, so now I didn't even go. So there's no need for me to go, because if I go, they will still do same. So then why not I just give her home? So we see these are some of the factors that affect access and utilization of these available services.
Okay, thank you so much, man. If you're a woman in Kaduna State, not even in Kaduna State, across Nigeria, please, when you go to access these services, please be patient. I mean, as much as we are saying that some of these places, they are far, the roads are not accessible. The ones you can access, please be patient when you get there. Not just even pregnant women, Nigerians as well. When we go to hospitals, be patient. We know the queues are long, the doctors are not many, the health workers are not many, the health workers are tired. They're also human beings, they are not robots. They are humans like you and I. So please, patience, it's needed. There are three things. What are three things you want us to know about maternal health in Kaduna State?
Well, maternal health in Kaduna State, just like I said, that maternal mortality is very high in states, which is number one, because we see that a lot of women in the states, they have issues with accessing the services because of their own personal or financial status. And then we also see that we have high mortality rates. And just like I earlier said, that reasons for this mortality rate that has to do with the educational, economic, cultural, some religious factors. Those are there. Then we also have low coverage for these health services. Like I said, in rural areas, we see that we don't have adequate manpower to provide these facilities for women. And then we also see shortage of manpower. In as much as the facilities are not available, we also have the shortage of manpower. Nevertheless, in the state, we also have good at various interventions, because at a point in time there were some facilities that were providing maternal kits to women who come to deliver. So when these kits were provided, we noticed that at the era of the provision for these kits, more women attended facilities to give birth, because they have this idea of incentives that will be given to them after delivery. So because I think the incentive was meant to reduce home delivery. So we see more women attending that facility, because they know that after putting to bed, they'll be given such a hamper to go back home with, and I think the hamper contains some things for their baby, like pampers, and then they are giving some little share, all some things to for the children. So those are some of the things that we see that are present in Kaduna State.
Thank you so much, Ma, for that. If you are made Kaduna Commissioner for Health, what will you do differently with regards to maternal mortality?
Okay, this is a very good one. Well, I will interface it in three dimensions. There is the immediate, and there is the long term, and there's also the intermediate interventions that you give. Like immediately now, since we have facilities that are already running, I will try to give this round the clock. We have this round the clock service for women, so that everybody at any time, whether you come in the morning, you come in the afternoon, you come in the night, you will have somebody to attend to you. You don't, because some of the health centers, once it's evening like this, it's like it's a forgotten zone. Meanwhile, these are places that people can supposed to be able to come in at any time, 2 a.m., 4 a.m., 6 in the morning. People should be able to attend it. So firstly, we will address that aspect. Then also addressing the aspect of adequate manpowers. We see that even the available ones, we need to take them for training and retraining. to step up their talents and whatever they know, because we know that one thing in the health is that there's this evolution, this dynamism, that constantly we need to help challenge the challenges that the health factor is facing, the health facilities are facing. We need to know it frequently, then train them so that they can know. Then the TBAs, these traditional birth attendants, whether we like it or not, they have come to stay, because some of these women, as far as they are not empowered, except we want to empower them now, that is when we will say, okay, traditional birth attendants, we can't even erode the system. We just need to train them. We just need to give them that certification. We just need to give them that explanation. Okay, if a woman is in distress, if a woman encounters prolonged labor, obstructed labor, refer her straight. Don't try to give your own thoughts. Refer her straight. And then even in the referral system, we need to provide measures to make sure that these referrals, they are quickly attended to. Like we need to provide buses, maybe tricycles, so that, because I've seen cases where we get narratives that when a woman comes to the facility and you refer them to a secondary or a tertiary care, the husband will just tell her, I beg, let me carry her home. Instead of going to the secondary care. But you see, if there is a proper channel where, okay, I will be the one as the health facilitator to take her to that secondary care, you see that there's no going back. The man has no choice but to take her there. So we see women in complications, sometimes they go home to go and die because nobody wants to care for them. I have a story where they said the woman was bleeding. The husband said he doesn't have a car, he doesn't have anything to use to transport her, and then they looked at her and watched her until she gave up. So we see that these are cases that could be tackled if maybe in the health facility there's an ambulance, or there is a proper channel to channel the woman immediately to a secondary care. We see that will not be there. We also see that in the long run also, we need to provide this community empowerment. Most of our community leaders, we need to empower them to empower their community, because you see that they are the voices for the community. Once there is proper awareness to these women, you see that some of all these, even the family planning services that they are supposed to acquire, most of them will tell you, you are a woman, God has blessed you with children, you should be able to give birth to as many as thousands of children you can give until your body naturally stops delivery. But we see that once there's proper enlightenment and sensitization from their, they will know that because you have some mites that are surrounding delivery. Then you also see that women need empowerment. Aside community empowering them, they need their own personal empowerment. Encouraging or giving girls free education is paramount in this region. Like because if you don't give a girl education, if she strives, or the father strives to take her to primary 6, immediately he gives her up for marriage, because he feels that he doesn't want her to become a nuisance, he doesn't want her to live a promiscuous life, so therefore let her enter into an early marriage. And then we see that this trend continues from one generation to another generation. So it's proper enlightenment, empowering the woman herself, because if you are empowered as a woman, you should also have your voice and decide and say, okay, this is good for me and I should want to do it. Then also financing these sectors, like we see that most of the infrastructures in these facilities, they are dilapidated. No drugs, no interventions. Then I also go into collaborations with NGOs and then foreign donors. We see that if there are collaborations with NGOs, some of these NGOs, they actually facilitate giving maternity kits to women. So with these proper collaborations to them, it can facilitate and help women, especially those who are pregnant, help them in their thousands, give them some of all these kits. It serves as an encouragement for them to utilize health services.
Thank you so much, Dr. Osamudiamen. I'm optimistic the current and future government of Kaduna State, they will listen to this and also implement it. And also, if there is need to also bring you on board to be the commissioner for health, they also bring you on board. Since you are the one giving them the ideas, since you are the one who brought up the ideas. I feel not just in Kaduna State, even the HT state where I come from and other states across Nigeria, they can utilize what you've said and improve the well-being of the women in the states, because when the mothers are taken care of, the families are taken care of. When the mother is affected, families are affected. The women are the bedrock of the homes and also our societies. Lastly, Dr. Osamudiamen, where do you see maternal health in Nigeria, especially Kaduna State, in a decade?
Well, in a decade, I hope best. I hope that in a decade we have better financing, we have better trained health personnel, we have better infrastructures, we also have better community health workers and better community leaders, that we already have this inbuilt knowledge, whose community will be free of all any hazards, and then you see that the well-being of the women is even better because they are educated now. Just like I've earlier said, that in a decade we hope for the best. We hope that as technology is coming up, as women are more enlightened, they should engage in more meaningful handworks. They should have more empowerment that will even help them to contribute to their society. So in a decade, I see Kaduna State actually changing, maternal mortality reducing significantly, and then we even meet up with the SDG goals, and make ourselves a better place.
Thank you so much, Dr. Chris. Thank you so much for the elaborate discussion. You dissected the paper on maternal mortality, maternal health across Kaduna State, what is needed, what is being done currently, and what should be done. So thank you so much for sharing your knowledge, your expertise, and also your time. Most importantly, your time. Time na money. As every Nigerian will say, time na money. Oh. So time is money. Let me not joke too much. Time is money. Thank you so much for sharing your time with us. It's an honor. And I believe everyone who is watching and everyone who is listening has understood what is currently happening regards to maternal health in Kaduna State, which and one thing with every state in Nigeria is it's a mirror. What happens at state level, what happens at local level, the primary health center is a mirror of what happens at the state level, and also a mirror of what happens at the national level. So if you compare what's happening currently in Kaduna State, if you compare to other states in Nigeria, they are more or less kind of similar or very little differences. And I believe in a decade, as we discussed, we'll have better health services. And please, if you've not read Dr. Osamudiamen's paper, that's basically the stuff to increase reading culture and also health literacy. Our paper elaborated extensively on maternal health in Kaduna State, especially in Sabongari. So if you've not read it, please read it. And if this discussion, as we're listening to it, most especially it's not just to listen to it, utilize it, share, discuss with your friends and family. That's what we want. Impact, basically, because there is no use of having the knowledge if you are not impacting yourself, and by impacting yourself you improve the well-being of yourself and also those around you. So thank you so much for joining us. Till the next episode, I can't wait for you to see the next guest researcher we are bringing on board. Have a blessed week.